Welcome, and thank you for joining us today. My name is Ellen Wilson, and I'll be the moderator for this expert briefing for the media, which is hosted by the Johns Hopkins Bloomberg School of Public Health. Today's experts will address the state of abortion access in the U.S. and the impact on women's health since the U.S. Supreme Court overturned Roe v. Wade last year. They will discuss the health risks of denying pregnant people abortions, how abortion restrictions worsen health disparities, and the potential ramifications of ongoing litigation to restrict access to medication abortion for women across the country. First, I'd like to briefly introduce our speakers. Dr. Suzanne Bell is an assistant professor in the Department of Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. She studies patterns of contraceptive use, abortion, and infertility and associated disparities, primarily in the context of population-based surveys. Professor Joanne Rosen is a senior lecturer in the Departments of Health Policy and Management and Population, Family, and Reproductive Health at the Johns Hopkins Bloomberg School of Public Health. She also serves as co-director of the Johns Hopkins Center for Law and the Public's Health. She studies the impact of law and policy on sexual and reproductive health, access to abortion, and sexual and gender minority communities. We will have time for questions following our speakers' remarks. We will take some questions that have been submitted in advance of the briefing and some from the Zoom chat. If you have a question, please enter it in the Zoom chat addressed to panelists and hosts. Please enter your name, media outlet in question. We hope to cover as many as possible. Please note that participants are welcome to use images, video, or quotes directly from the briefing, and that the content is for immediate release. Participants will be muted during this briefing and it will be recorded. Suzanne, please go ahead.
Great, thank you, Ellen. The Dobbs v. Jackson Women's Health Organization Supreme Court decision was a devastating and unprecedented reproductive health policy change with potentially significant implications for reproductive autonomy, fertility, and maternal and infant health in the U.S. that will only become apparent in the coming years. Approximately 1 in 3 people who can become pregnant in the U.S. currently reside in a state with little or no access to safe abortion services, predominantly in the South and Midwest, where a disproportionate share of the population is Black or Hispanic. Restricting safe abortion services will undoubtedly differentially impact the reproductive self-determination of many disadvantaged groups, with long-term negative repercussions for population health and disparities. Structural inequities result in an overrepresentation of poor and minoritized individuals among people seeking abortion care. Pre-Dobbs, the annual induced abortion rate was 14 abortions per 1,000 reproductive age women in the U.S., with rates 2 to 3 times higher among Black and Hispanic people, those experiencing poverty, and those who were unmarried. And these populations are likely encountering the greatest difficulties obtaining an abortion in restrictive states post-Dobbs, and are also at greater risk of poor pregnancy and birth outcomes, including late entry into prenatal care, preterm birth, low birth weight, and severe maternal morbidity and mortality. It's important to highlight that pregnancies carried to term are associated with a risk of maternal death that is 15 times higher than that of abortion, and pregnancy-related complications are nearly 2 to more than 25 times higher for pregnancies ending in birth compared to abortion. Additionally, states that have abortion restrictions also have poor maternity care that is marked by inequities. Thus, abortion restrictions imposed since the Dobbs decision may increase rates of these negative pregnancy outcomes and widen disparities simply because more people who reside in these states, especially disadvantaged populations, are exposed to the risks associated with carrying a pregnancy to term. Post-Dobbs, abortion restrictions may also directly impact risks of these outcomes via changes in clinical practice, accessibility of timely maternal care, and increases in stress associated with unintended pregnancies, which has negative repercussions on the pregnant person and the developing fetus. And we already have some evidence of the myriad impacts of recent abortion restrictions. Research from the Society of Family Planning evaluating changes in abortion provisions since Dobbs indicate there were 32,000 fewer facility-based or telehealth abortions nationwide in the 6 months following the decision. Some expect self-managed medication abortion will fill this gap. And while online requests for medication abortion pills have increased since Dobbs, it's unlikely this increase will fully offset the decline in abortions provided in the formal healthcare system. As most people are still not aware of this option, it can be costly, and delays in pregnancy recognition, coupled with delays in receipt of the medication abortion pills via mail, will push many people beyond the FDA-approved gestational limit of 10 weeks for medication abortion. As to the impacts on other outcomes, we can look to research evaluating the impact of Texas's Senate Bill 8 in September 2021, which banned abortions after 6 weeks, for insights regarding what we might expect following Dobbs. My colleagues Allison Gemmel, Elizabeth Stewart, and I currently have a paper under review that looks at the preliminary fertility impacts of SB8, and we see a significant increase in monthly counts of live births above expectation in Texas, beginning in June 2022. Other work by authors Nambiar et al. Out of 2 large hospitals in Texas observed a near doubling of maternal morbidity associated with state-mandated expectant management of pre-viable rupture membranes compared to termination at time of diagnosis, 57% versus 33%. And this was just in the 8 months after Texas's 6-week abortion ban was imposed. These results are a sad harbinger of the potential fertility and maternal health impacts we might expect to see following similar abortion bans and several severe restrictions associated with Dobbs. In closing, I want to emphasize that abortion is healthcare. Recent state restrictions, coupled with ongoing efforts to curtail access to medication abortion pills nationwide, are an attempt to interfere with the delivery of evidence-based healthcare and control pregnant people's bodies, with harmful consequences for individuals, population health, and population health disparities.
Thank you, Suzanne. Now we will hear from Joanne. Joanne, please go ahead.
Thank you. Good afternoon, everyone. Abortion in this country has long been deeply intertwined with the law and the political process, but the Dobbs decision has intensified the scope, the pace, and the stakes of legislation, litigation, and political activity over the last year. The implications for public health, as Dr. Bell just described, are manifold and severe. As you know, Dobbs returned the issue of abortion regulation to the people through their elected representatives, meaning that states and Congress are now free to regulate, restrict, and even ban abortion without the long-term constitutional protections that had been exerted by Roe versus Wade and Planned Parenthood versus Casey. And this shift in power to state legislatures actually began to be observed even before the Dobbs opinion was released, and it has continued in the legislative, political, and litigation spheres post-Dobbs. To be really clear, states on both sides of the abortion issue, abortion hostile states and abortion protective states, anticipated and then subsequently responded to Dobbs. And let me take a couple of minutes to give you some examples of what I mean. First, abortion hostile states. In 2021, the year before the Dobbs opinion was released, abortion hostile states enacted 108 abortion restrictions. This is the single highest number of abortion restrictions in any year since the Roe decision was released in 1973. With the change in composition of the Supreme Court, some states began legislating in anticipation of the reversal of Roe, even though this was prior to Roe being reversed. In 2022, there were 50 additional state abortion restrictions enacted, and many of these restrictions were outright bans or near bans. And then in the 11 months since Dobbs was released, abortion has been banned now in 14 states and is currently unavailable in 14 or possibly 15 states. I was unable to get the most up-to-date tally. An additional 8 abortion bans are currently blocked by court order. This may not be the final tally of state abortion bans. There are 26 states that participated in the Dobbs case and asked the Supreme Court to reverse Roe and Casey. If people are interested, 2 really good resources to track legislative activity on abortion restrictions in near real time can be found at the Guttmacher Institute website and at Temple University's Center for Public Health Law Research, or Law Atlas. On the other side are the activities of abortion protective states. Abortion is currently legal in 20 states, and 15 of these states have enacted additional protections. The protections vary by state and have included a range of laws, such as state laws that permit the use of state funds to cover the cost of abortion, laws that allow advanced practice clinicians, that is, non-physician licensed health professionals to perform abortions. This expansion to advanced practice clinicians is important because it expands the pool of authorized providers available in a state. Shield laws that protect physicians in abortion protective states from prosecution, extradition, or other forms of legal action taken by states that ban abortion. Laws that protect the disclosure of patients' medical records without patient permission. In addition to all of these abortion protective laws, and that is only a sample, since Dobbs, 6 states have had abortion-related measures on their ballots. Each of the abortion protective measures passed, and each of the abortion restrictive measures were defeated. I want to move briefly to the litigation front, and in particular, because so much of attention has been drawn to it, litigation to restrict access to medication abortion. It's really been clear in the last many months that there are some abortion opponents now taking action to extend the reach of Dobbs and abolish abortion nationwide. To be clear, that means even abolish abortion in states where state legislatures have opted to protect or expand abortion access. It well appears that the reversal of Roe and Casey was only the beginning and not the end of efforts to end abortion in this country. These efforts are currently happening in 2 ways that I wanted to highlight: through litigation to remove access to mifepristone across the country, and through measures to revive and enforce the Comstock Act. By my count, there are 6 ongoing legal challenges right now involving mifepristone. 2 of these challenges seek to remove access to mifepristone, and 4 are seeking to broaden or protect this access. The case that is especially consequential at the moment is Alliance for Hippocratic Medicine versus FDA. That's the Texas case. It has been extensively covered, but I will touch on it briefly. This is the case that was argued yesterday in the Fifth Circuit Court of Appeals. The plaintiffs in this case are a coalition of anti-abortion organizations and physicians, and they are seeking to revoke the FDA's longstanding approval of mifepristone and thereby remove it nationwide. And to provide just a bit of context, medication abortion has been the most common method of pregnancy termination since 2020. In the year 2020, it was used in 53% of abortions. It has also been safely used by over 5.3 million women in the US since the drug was first approved in 2000. The plaintiffs in this case obtained a preliminary order in April at the trial level that stayed all of the FDA's approvals and decisions on mifepristone nationwide. And if that trial level order had been allowed to remain in effect, it would have blocked lawful access to mifepristone, even in those states that have elected to protect abortion. Following 2 very intense weeks of emergency appeals, the Supreme Court blocked the preliminary stay, and they reinstated access to mifepristone, or the mifepristone status quo, for the duration of the litigation. The implications of this case are extraordinary, and they include the potential termination of access to mifepristone, a precedent for court interference in the FDA's rigorous and science-based testing and approval process, not just for mifepristone, but for any drug. And of note, if the challenger's case succeeds here, this would be the first time in history that a court has abrogated the FDA's approval of a drug over the objections of the FDA. And it would also be a precedent that would result in the substantial alteration of the Supreme Court's rules with respect to standing, or who is legally entitled to bring a challenge, and would thereby open the door to a near infinite class of persons who could challenge the FDA's approval of this or any other drug. Finally, the Dobbs opinion has breathed new life into some abortion opponents' efforts to enforce the 1873 Comstock Act and to try to employ it as a tool to thwart abortion nationwide by banning the mailing or transport of abortion pills and potentially the mailing of medical instruments and devices that are used to perform procedural or surgical abortions. And the Alliance for Hippocratic Medicine case is an example of this strategy. I expect that we will see a lot more litigation of this type, including efforts to use the Comstock Act as another means of banishing abortion nationwide.
Thank you, Joanne. Now we will take questions. Again, reminder, if you have a question, please enter it in the Zoom chat with your name, media outlet, question, and to whom you'd like to address your question. To start us out, here are several questions from freelance journalist Tara Hale. For you, Suzanne, if we want to point to data showing actual effects that did happen from a particular restriction or from complete removal of access in this or that state, when will that data become available, and where or how are the best ways to find it?
Great, thank you for this question. So given the timing of not only gestation, but then when data become available about pregnancies, not only the live births, but complications potentially associated with it, we're maybe just starting to see results from the Texas bill that passed in 2021. But the Dobbs decision happened at the end of June. So the earliest birth cohort for whom we might expect to see fertility, maternal health, and infant health impacts is perhaps May 2022. And that would correspond to full-term pregnancies ending in January, February 2023. And those data from the government, from the National Center for Health Statistics, wouldn't be available until at earliest probably mid-2024. So there's quite a bit of lag. I think the first evidence we'll start to see is from folks who are first looking at the impacts on abortion service delivery, like Society of Family Planning, and then these longer-term fertility and maternal and infant health impacts, not until probably later in 2024. Morbidity and mortality statistics and hospital administration data that are all needed for those other outcomes, there'll be even a longer lag because those data take longer to become available to researchers. So unfortunately, we're going to have to be patient for a while, but I think what we start to see coming out of evaluations of Texas's SB8 bill, like I said, will really be a good indication of what we might expect for implications of specific state legislation changes that occurred post-Dobbs.
Great, thank you. And any follow-ups on where or how, the best ways to find this data?
So I can share some links, but for the fertility data, those are available through the National Center for Health Statistics, which is under part of the CDC. So those data are on CDC Wonder through 2021 and are publicly available. The 2022 data are provisional. Those are also publicly available, and subsequent data will be released on their website there as well. The other data, the government uses administrative hospital discharge data coupled with codes to try and determine maternal morbidity and mortality. And those are also going to be available through the CDC.
Great, thank you. Next question for both of you, starting with Joanne. What aspects of the impact of the Dobbs ruling and the subsequent restrictions across the US are not getting adequate coverage in the media? In other words, what part of the story is being missed or simply being underexplored?
So I would say overall, collectively, the press have done a phenomenal job of covering a really wide range of public health and public health law and policy issues around Dobbs. Two things that I'm thinking about and would be wonderful to see more reporting on are the existence of risk management committees that have been created in the hospitals of states that ban abortion. These are committees that now have to determine whether in an urgent healthcare situation where abortion may be necessary to save or protect the life of the pregnant person, whether in fact an abortion can be provided in that context. So I think, and I know anecdotally from conversations with clinicians, that they have been finding it very difficult to be able to practice best medicine and protect the well-being of their patients in these abortion hostile states and have to run this by these risk management committees. And they're concerned about the cautiousness or conservatism, again, because there are genuine risks of criminal prosecution. So I think some additional reporting on the ways in which these hospital committees have had to be an interface between patient well-being and clinical care. Another point related to the Comstock Act. The Comstock Act is what could be described as a zombie law. It is a law that until the reversal of Roe and Casey had largely been regarded as ineffective and invalid. But with the change in that precedent, there are efforts to revive it and bring it back to life. There has been some reporting on the Comstock Act, but there are other similar types of zombie laws that I think merit consideration. When Dobbs reversed Roe and Casey, there was an entire lineage of constitutional cases involving access to contraceptives, the legality of same-sex consensual sexual activity, same-sex marriage, interracial marriage, but they're all in the same constitutional lineage. And there was real concern that reversing Roe and Casey could weaken the underpinnings and give rise to a revival of reverse those other cases. And there are, for example, a number of sodomy laws that have been invalid but are still on the books and were never reversed. And Dobbs could be a fulcrum for some negative states trying to revive these sodomy laws or trying to revive old birth control ban laws. A colleague and I wrote a piece subsequent to Dobbs back in the fall discussing specifically zombie laws and whether they pose a threat. So some research on these zombie laws, including the Comstock Act, I think would draw public attention to something that really is an issue.
Suzanne, anything to add in terms of issues not getting adequate coverage?
Sure, briefly. Also want to commend the media. I've been particularly impressed by the sustained coverage abortion has received post-op, so thank you. And to a point that I alluded to in my opening remarks, the populations we anticipate will be most impacted by increased barriers to abortion access post-Dobbs. Minoritized women, those in poverty, are also at greatest risk of poor pregnancy and birth outcomes regardless, including some of the outcomes I mentioned, like late entry into prenatal care, preterm birth, maternal morbidity and mortality. So even outside of changes to kind of clinical practice or receipt of care, simply a compositional shift in the birthing population due to these abortion restrictions could increase the rates of adverse maternal and infant pregnancy outcomes, even without changing those risks directly. And so I think it's a little nuanced, but the focus has been so much on abortion and what these restrictions will do on abortion that it kind of sometimes loses sight of these broader long-term population health implications. As a demographer, I always kind of have those in mind. And I think also just kind of broadly framing or emphasizing that this isn't just a women's health or pregnant person's health issue, really emphasizing the broader impacts on partners, families, existing children, and societies is important to get others perhaps to be more invested in this issue. That's it.
Great, thank you. Here's a question from Mariana Lanjaro at Nature for Joanne. What are the possible decisions by the Fifth Circuit Court in the case Alliance for Hippocratic Medicine versus FDA, and what happens next?
So I think what happens next in terms of continued access to mifepristone is that there will be no change in access to mifepristone because the Supreme Court, in its ruling on the emergency stay, said that mifepristone would continue to be available under the terms of FDA approval for the duration of the litigation in that case, up to and including an appeal to the Supreme Court. So in the short term, there is no change to access to mifepristone. At the moment, as you know, the Fifth Circuit heard the appeal to Judge Kaczmarek's ruling yesterday. At some point, I have no idea, I can't predict when, at some point the Fifth Circuit will rule and they will either narrow the access to mifepristone, try to block it altogether, and then that opinion, if it's unfavorable to the FDA, to the Department of Justice, will likely be appealed to the Supreme Court. But as I said, that will not have any actual impact on access to mifepristone because the Supreme Court's order will prevail in the short term. So we'll have to wait for the Fifth Circuit opinion, and then presumably there will be an appeal to the Supreme Court. And I don't think that will go on the kind of expedited basis that we've seen so far, because the immediate urgency of upending access to mifepristone has been calmed dramatically. So I think the Supreme Court will probably hear it kind of in the normal course. I hope that answers the question.
And if I can just add in terms of the kind of broader public health implications, if ultimately we have an unfavorable decision from the Supreme Court, this restriction on mifepristone will not stop medication abortions from occurring in the US. It will simply force healthcare providers to rely on the misoprostol only regimen, which, while still very safe and used in many parts of the world, is somewhat less effective and causes more uncomfortable side effects.
Yes, and I think that from Joyce, this is just more follow-ups from Joyce Frieden at MedPage today. I think you've really answered this, but again, it's with regard to the Fifth Circuit Appeals Court case. Will the decision either way have any effect on access to reproductive health care, since it will almost surely be appealed to the Supreme Court?
So I think I have answered that, and at least in the short term, even if the Fifth Circuit decides to agree with Judge Kaczmarek's ruling in total, his preliminary stay would have taken mifepristone off the market. It will not, in fact, have any impact on access to mifepristone because the Supreme Court's order will prevail over what the Fifth Circuit says. The reasoning in the Fifth Circuit opinion, though, it does not mean that what the Fifth Circuit does is meaningless or irrelevant, because the reasoning, what the Fifth Circuit does, may be something that some justices on the Supreme Court agree with and incorporate into their ultimate decision. So there will be, pragmatically speaking, no change in access to mifepristone while the case is being litigated, but the opinion of the Fifth Circuit may, in fact, parts of it may be incorporated by some justices of the Supreme Court.
Thank you. Thank you for the further clarification. Here's a question from Sandhya Raman at CQ. Roll call for Suzanne. I'm interested in some of these effects on workforce and medical education. Are there signs or factors you're watching in Texas or elsewhere post-Dobbs that show how this could affect the number of reproductive health providers now and in the future?
I think the biggest potential negative repercussion that this kind of policy landscape around abortion will have on reproductive health service delivery is where people choose to work. We've already seen in rural areas hospitals closing, and that was happening before Dobbs, but that is happening more so specifically because some hospitals in restrictive and hostile states are having difficulty attracting obstetricians and gynecologists, given this really kind of challenging legal environment that they are potentially operating in a context where, there is lawyers increasingly involved in healthcare decisions being made and how to treat pregnant people. And so I think it's going to exacerbate existing disparities in where trained reproductive health providers are operating and working. And that was a disparity that already exists. We have maternal mortality rates that are in some cases twice as high in restrictive states than they are in supportive abortion states. There's more demand for obstetrician and gynecology training and residency programs than there are spots. And so I think it's more a matter of what's going to happen to where those trainings are taking place. Are they going to entirely leave hostile states and set up their training program elsewhere? Or are the people that receive training in those states just not going to receive the appropriate training related to, miscarriage management, abortion, et cetera, that should be standard? So I think we have yet to see what those full ramifications are.
Great. Here's a question back to the Fifth Circuit's decision. This is from Susan Dunlap at the New Mexico Political Report. How does the Fifth Circuit's decision on mifepristone impact states like New Mexico, which participated in the Eastern Washington lawsuit on mifepristone?
Right, that's the Washington State versus FDA lawsuit in which 18 Democratic attorneys general were seeking to have the remaining additional conditions on mifepristone removed. Because of the Supreme Court's decision with respect to ensuring that mifepristone is fully available throughout the country, there will be no sort of ramifications for New Mexico as a party to the Washington State litigation. They're looked for a very short period of time like there were conflicting orders. Judge Rice in the Washington State decision had ordered the 18 states in that litigation not to make any changes to mifepristone access. And he ordered that about 20 minutes after Judge Kaczmarek's first ruling in early April. And so it looked like there was this conflict between what Judge Kaczmarek was saying had to happen nationwide and what Judge Rice was saying would happen in those 18 jurisdictions. But the Supreme Court's ruling with respect to mifepristone access has lifted that conflict, at least for the time being.
Great, thank you. And last question for both of you. When it comes to escalating abortion restrictions, is the U.S. an outlier when compared to other countries? Let's start with Suzanne.
Yeah, this is a good point. I think we sometimes can lose sight without having context for what's happening globally. But the U.S. is really an anomaly with regard to the increasing politicization and restrictive laws around abortion. Around 59% of the world's female population currently reside in a country where abortion is broadly allowed. And generally, over the past several decades, there has been a trend towards increasing liberalization. So this is part of a very unique, change in policy happening in the U.S. that is a real outlier among global contexts.
Great, thank you. Joanne?
I agree. Nothing to add.
Okay, great. Thank you to both of you for your presentations and insightful answers. And to the participants, we will email all the links to the resources mentioned today and shared in the chat. And with that, I'd like to say thank you again to everyone for joining us today.
Thank you. Thanks, Ellen.
Thank you.